Thanks for coming back to my channel. My name is Ekta and I'm a third year university student at the University of Northampton. On our last leg, guys, come on, we can do this. Okay, so today we're talking to somebody really, really cool. His name is Priten Chohan-Solanki, and we will be discussing clinical decision making and the three important factors, maybe four, I think, important factors of clinical decision making. And I think as students, it is incredibly important that we understand how this relates to our future as podiatrists, and learning these skills and learning these three essential concepts right away. Or, I mean, I guess not right away, but it's good to kind of get that, these three pillars down so that we've got that skill in our toolbox, and we graduate with complete confidence that we can make apt clinical decisions. Although most of that is pretty much based on experience. So we'll say a little bit confident, not maybe fully confident because we don't want to be cocky. Anyways, stick around for the interview. Let me know what you think and leave your comments in the description below if you have any questions for myself or Priten. Thanks. Enjoy. Hi, Priten. How are you?
I'm good, thanks, Hector. How you doing?
I'm very well. Thank you. Thanks for joining me here today.
Yeah. It's been we've had a hot day here in Cardiff, so
Lucky. We got rained on this last few days. Actually, before the weekend started, we were just getting like heaps of rain in Northampton, and I'm like, oh, this is horrible because we had like such lovely like sunshine weather right before like the rain just poured on us. So it was nice. Also, I just wanted to say thank you for your feedback for the article I wrote about insole making and stuff.
no, that's fine. That's fine. I understand it can be a bit difficult, and it always any little helps. After I used to teach that, as I mentioned in the feedback. So
That's really cool. So, was it just a singular course you were teaching, or were you an instructor? How did that work?
I was a clinical tutor, and so one of the responsibilities I had as a clinical tutor was to take the students into the lab, kind of go through the process of making a pair of orthotics, and then when I moved to Australia, I was responsible for that part of the course, and then sort of when I came back, kind of flipped into sort of old job really. So it's kind of been doing a lot of that, and it's one of those things that I look at, and you always look at it and you go, oh, let me just touch this bit up here, and then you realize you've messed it all up.
Yeah, I can't relate at all. I've totally done that myself. So was this in solid, like was this before podiatry? Was this in sync with podiatry, side by side podiatry, or did you
Oh
do
no,
podiatry
this
after?
was as in podiatry. So
Okay.
was it? I've been in the game for about 20 years now. So I've been teaching, and I was teaching for about 15 years of that. So it was always spent a lot of time in the lab and sort of making devices for patients as well as instructing students. So I'll put that down to my first job. They stuck us in the lab, say here's a list of 15 orthotics you need to get made by this afternoon. I was like, oh, thanks.
Oh, that's crazy. And is it just modifications or just like starting from scratch?
Starting to scratch non-cast insoles.
That's hard. I mean, that would take forever. I mean, it took me one full day to make just one pair of orthotics.
You get once you get going and you get the used to the process of it, you can knock out about I could probably knock out 20 a day if I wanted to, and I had the right equipment.
Right. That's
Just in
nuts.
clinical.
That's incredible. So as a part of, being an instructor do you have to make sure that your students know that clinical decision making goes in hand when you're making insoles?
Yeah, so you're making a decision on what you're going to make for that patient. So how you come across, how you make how you prescribe the device is your decision. It's based on your clinical information and how you put that into a prescription for a device, which is and the really hard thing I found, particularly with students and even myself when I was way back when, was a case of you'll realize that you'll do the same prescription for lots of different pathologies, but it's all to do with what you're trying to achieve and how you're going to either offload tissue, move load to another tissue, and looking at those sorts of aspects and how do you come to that clinical decision. So I got introduced to the theory behind decision making when I was teaching in Australia, um, and it was really quite interesting because you kind of have to think about, it makes you think about how do you come up with your decision, how do you use the information that's given to you, and how you yourself process that information.
I see. Okay. And it's unique for every practitioner, I'm assuming.
Yeah, it's unique for everyone. So it basically gets you to look at your own, look through things that in your own sort of experiences. Because I think, if I remember correctly, the theory goes there are three aspects to sort of the clinical decision, your clinical decision. So this first is the patient and their expectations. What do they want to get out of it? So how does that fit in what you can do and you can't do? There might be, they want to wear a particular type of footwear. If it comes to making a pair of orthotics, you need to make sure the orthotic you make fits in the shoe they wear. My old adage is a pair of orthotics is only as good as the shoes it goes into. So, and if the patient's going to wear it, a good orthotic's a worn orthotic. So,
Yeah.
so there's that aspect. There's you as a practitioner. What's your experiences of the patient's experience and the patient's conditions, and how do you think there are things that they would respond to, how they wouldn't respond to? And then above that, then you've got sort of your evidence-based medicine. So it's all your research and all of that sort of stuff says, oh, you should do X, Y, and Z for this condition. But does that fit into, one, what do you have available in your clinic? Two, what is the patient able to do that part of the evidence base, and how you kind of process all of those things together to come up with a decision and a plan that works with the patient, if that makes sense.
That no, that totally makes sense. And I feel like once you explain it like that, it's like one of like, you kind of feel like saying, well, yeah, that's so obvious, like that, that makes sense because it follows like a logical thought pattern. But then when you're talking to a patient and you're trying to explain evidence-based practice, how do you explain it in a way that makes sense to the patient where they just don't look at you and go, this is essentially a robot talking to me? Like, how do you explain it on terms that they will understand?
That's the golden answer of communication there. How do you make patients listen?
Do you have any tips?
The way I've always tried to approach it is always think about frame it in the patient's goals. So what's their expectations? What do they want to achieve? And how do you sort of frame that sort of management plan in the way that they perceive it to be useful to them? It's kind of it's really strange because you got to kind of get into their mind frame. You have to be the patient for a moment and go, okay, what would I, if this person told me to do this, would I actually do it? So
Yeah.
and we know concordance with patients is variable, and a patient that trusts you as a practitioner is more likely to sort of go with a few things, go with what you suggest, than if you're just reading off the script. So the plantar fasciitis script is you do your stretching, you do sort of some rolling, all of those things. There may be things that they've heard 101 times before or read already online, but is there anything else that you can add to sort of help them along their way a little bit?
Yeah, I understand what you're saying. So then my next question is, how do you build that trust with the patient so your communication therefore is much better as a result?
So I'm going to come back to you with a question. How do you frame your consultation? So you get a new patient. What's the first thing you get them to do? What's the first things you do in clinic?
Well, you get them to fill out forms, like new patient forms, and then you ask them, okay, what's brought you in here today? What's hurting you? And then you do your assessments, you do your new patient assessments, you check their blood pressure, reflexes, all the good stuff. And then,
and that's all great, but where are you sitting and where's the patient sitting?
we're sitting across from each other.
So this is where the sort of this is, who's in the position of power there?
Oh yeah, I guess the practitioner would be.
Who's in control? So
Yeah.
because I used to do the same. Patient used to sit on the couch in front of me. I would look at them and say, right, what are we going to do to you? I've changed that to as simple as having a chair next to the couch, getting the patient to sit on the couch first and then give me what's wrong with them first, and then run through everything on the same level,
Oh, okay. So side by side.
side by side.
Okay.
So you kind of have it. I know it's difficult in certain time pressured situations, and if you're working in sort of private practice, you can choose however long you want to spend. But it's a skill in that history taking that you kind of take down a lot of what they say, and with experience, you're then able to filter what they're saying as well.
Mm.
So, but again, it's that having that rapport to start with to go, right, what's going on.
Okay, so I feel like there's like a little like psychological trick in that by sitting side by side. So is there, what else can we do to help build that trust where it's not so like blatantly obvious, but it's just something as simple as sitting next to your patient?
It could be as simple as that. It's then also obviously things like active listening. So obviously listening to what they're saying, but then kind of sort of saying, okay, if that's what you're saying, is that, then kind of just repeat it back to them just a slightly different way. So you sort of, they realize that you've taken on board what you've said and
Okay.
and then you've processed that information as well. So as we said earlier, is that you've got the three components of how you come to a decision. That one is you, one's the patient. So you recognize things as humans, we recognize and store information as patterns. So if you're making sure that you're listening, you're taking note of the appropriate items from your history, then those patterns, you'll start to find those patterns that you can kind of help you get to your diagnosis.
Okay. So
Some
one is sitting next to your patient. Second one is validating that their pain is real and they feel it, we feel it for them as well. So
Yeah.
just validating how they feel. What's the third one? I feel like there's like, it always comes in threes.
The third one, I haven't actually thought of a third one, but the third one is making sure, and there's a really, actually, there is a third one, and it again comes back to the patient positioning and how you set up your room. And a lot of this research has been done by sort of nursing and sort of how they get information from patients as well. Is where do you, again, partly positioning yourself next to your patient, and then how do you sort of relate to your patient sort of with physical touch? Are you quite rough-handed? Are you nervous? Are you firm but in control? So there's that sort of non-verbal as well.
Mm-hmm.
So again, even little things like while you're listening, you're leaning in, you're paying attention, and just those sorts of things will garner a bit of trust from the patient to what you're saying and
Yeah.
what information that you're kind of getting from that.
I think one thing that really reminds me of is so when how our cubicles are set up in our class is that we've got a chair, a couch obviously for the patient, and then we've got a tablet connected to the wall of the cubicle, and a little stand that holds the tablet, and we've got a little keyboard. So I'm trying to look at the patient, trying to take in everything that they're saying, but at the same time, I'm spending a lot of time trying to write as quickly as I can what they're saying to me. So I'm not even making eye contact. So would you say eye contact is a very,
Yes.
very big thing?
So like I get that in my clinic. So I have a laptop set up to one side. I've got the patient there. I would sort of ignore the computer to start with and sort of say, and kind of go through those initial stages and say, right, give me a second. I need to jot all this down before I forget it. And you tell the patient what you're doing. So it's not a case of, yeah, I'm just listening to typing away on the computer and just looking away. It's kind of, that's kind of a little bit dismissive sometimes. So you kind of want to make sure that you tell the patient what you're doing. They won't mind you stopping for 5 minutes and getting things down. But again, it's just taking, again, you're like, they will notice that you've taken that on board. And there's a lot of information that comes out of the history that, yeah, you need to write it down as you go along. But obviously you don't want to be, we've all been to see the GP who's been there typing away. You've just sort of chatted away to them for 5 minutes. They've not actually looked up from their screen.
Yeah.
And then you it sounds really bad, but you leave feeling cheated. That
Okay. I get that. Yes. I understand what you're saying. Yeah. 100%.
so again, it's that technology has become a huge part of what we do, but it shouldn't rule what we do.
Okay.
And again, it's that personal contact making with patients that will get them to open up and then be able to give you a better history.
Mhm. Oh, those are really good feedback points, and it's something that we can all like start implementing as students. Because like for now, like I mean, as a student, I feel like the main thing is like trying to make sure our medical history taking is like is on point. But at the same time, I think sometimes we do tend to like overlook that essential need of connecting with a patient.
Hmm. And again, I don't want to sound bad on the NHS, but there's limited time, obviously, and it, you get that connection that you see with patients on a regular basis. And one of the things that struck me a lot was we as podiatrists will actually see our patients a lot more than they will see their practice nurse or their GP.
Why is that?
If you've got a patient on sort of regular routine podiatry care, you'll see them every 6 to 8 weeks or so.
Hmm.
You'll see them probably what if you're on an 8 week return, an 8 week return, then you'll probably see them maybe about 6 times a year.
Hmm.
I don't go to see my, I don't know anybody who goes to see their doctor or nurse 6 times a year.
This is very true. Yeah.
So again, we should be thinking more in terms of that sort of holistic and what else is going on in their life that make that consultation count.
So what other things would you say to ask or to pick up on to give like us a holistic view of the patient?
How you doing? It can be as simple as that. How you doing today? There hasn't necessarily need to be any sort of agenda behind their health or anything like that. It's like, oh, okay, how you doing today? How did you get here today? Did you have any problems getting in? Because again, that kind of reveals like, are they able to drive? Are they using public transport a lot? Are they did they have to get up really early to be able to get to you? Those sorts of little things that you kind of like, oh right, okay, they're very active in their life. And it's always, I always come back to this, is that you always come up, think you've done a bang up job with your history. You always be thinking, fantastic, this is great, I'm going to present this to my tutor now. Okay, and I've smashed it. Here it is. And then the tutor asks one question and you go, oh, all of that was for nothing.
Yeah.
Yeah, we've all been there, and it's just a case of like, and that's where coming back to identifying those patterns and then kind of asking those probing questions at the right time can actually is the skill that we all develop through time. And without seeing those patients, without expanding our our base and our reference base, we're not going to be able to see those. Like personally, I do a lot of musculoskeletal work. I've done some surgery stuff. I would struggle with a diabetic patient. I could debride a wound for you, but kind of getting into it to the nitty and gritty, I'd struggle because that's not my frame of reference.
Okay.
And again, as we specialize more and more, we got to make sure that we, like us as practitioners, are aware of what our frame of reference is. And again, that stops you getting into sort of points where you're probably meddling in things that you shouldn't be meddling in, and where you should be making those appropriate referrals.
Okay. So is that something that we need to start thinking about as students? Like what can be our frame of reference? Like if are you leaning more towards diabetic care? Are you
Not
leaning more towards
no no not that, not as students. You try and kind of keep that frame of reference, but your frame of reference in terms of what I mean is your experiences. So your experience, like my experience since graduating, I did a couple of years of NHS work, then the rest has been in education, and I've just gone into private practice now. So it's that I can talk a lot about the patients I've seen in terms of a musculoskeletal, but I haven't seen many wound type patients. I've seen some, but not a huge amount. But it's knowing where your limits lie as well.
Okay, and this is something that's purely experience based.
It can be, and it's one of those things that we will, where you kind of like, you've seen a patient and you go, I'm not 100% sure what's going on here. I'm going to go ask for help. And and we've got to, as practitioners, and a lot of us work on our own, have got to realize that we can't answer everything on our own. We got kind of do need to reach out for help, whether
Mhm.
that be a colleague to practice. I'm lucky. I work in two clinics where it's multidisciplinary. We've got physios on site. We've got a chiropractor, sports therapists. So I can kind of go to them and go, this doesn't sound right. Would you mind having a look? There was a patient I saw This week, having trouble with his knee. Originally, it was a few things, and he'd been referred for a biomechanical assessment. So we did that, did some taping, did some lifts and things like that, see if that made any difference. It made no difference whatsoever. And then he mentioned about his knee, which didn't come out in the first analysis. Tested his knee, really unstable medially and laterally. So now I'm going, right, you need a brace on that knee. I'm going to refer you to an orthotist.
Was it just on one side, or
Yeah,
was it? Oh,
one
okay.
side, one side, and it's that it stops it. Then it's the knee more than anything else that stops him from doing stuff. So,
Okay.
so it was just a case of going, right, okay, I think you need an MRI on the knee. You need an orthopedic consultant, and we need to brace that knee because that's really unstable.
Yeah.
So it's a case of then sort of knowing when to refer, when to sort of continue doing, because I would have thought he had a limb length discrepancy, that sort of stuff. We did all the normal things you would do for something like that we thought would take stress off the knee. Made no difference whatsoever. So I think there's something more in depth going on with that knee than you can correct with foot orthotics.
I have a really dumb question. And this is only because my partner, he brought it up because he went to go see a physio himself for a knee related problem, and he was only bracing, not, I guess not bracing, but he was using what do you call it? Like it's like a little wrap for
A
the knee.
TheraBand.
Yeah. So no, like just a thing to wrap the knee.
Oh yeah.
So he was only doing it on one side, and he said that his physiotherapist at that time said, why are you only just wrapping one knee? You should be wrapping both. Now, is that something like we should think about? Like if you're just protecting one knee, should you be protecting both at the same time? Like, do you
Yeah, it's a case of, okay, it kind of came for me in this case that I saw. It was a case of there was obviously deficiency in one knee, so that knee needed attention. Now it's a case of, I would kind of come back to, is there a pathology in the other knee, and does that need treating? And if the other knee's fine, then then you might not necessarily need to treat that.
Okay.
So it's a case of, is the contralateral side contributing to the problem on the bad side? Then you'd start treating the other side. But if it's just a unilateral problem, so say if you had somebody, I would bring it, if you had somebody who had a ankle sprain on their left ankle, you might put them in an ankle brace or that use a support for that left ankle, but you wouldn't necessarily support the other ankle because it's no problems with the other ankle.
Okay. I see. Yeah, I see what you're saying. Yeah. Yeah, no, that makes sense. I was just confused by like I guess like the story that I heard of the physiotherapist. But no, it's always good to have just different opinions on like one issue, because then you can like learn lots of things.
Definitely, and then that's where you kind of like, that's where you start questioning, like, okay, how did you come to that decision, and why would you say one, why I should be wrapping both? What's their rationale behind that? So their rationale for that might be completely valid, but might not set with your sort of your frame of reference. So it's one of those things where you start learning.
Mm-hmm.
And one of the things that I always say to students is, if somebody makes a decision or they've come up with something that you're like, okay, that's a bit weird, ask them about it, because it's not, and particularly if that's on placement or in uni clinics, ask them, how did you come to that decision? Why was that suitable for that case? Because you might see something similar, but that treatment might not be suitable for that second patient.
But then like as students, how do we, I mean, if we start asking those questions, like would we kind of be stepping on toes or no?
Well, I wouldn't personally. It would depend on the practitioner. Like for personally, I wouldn't care. I'd be happy to tell you, because you're there to learn, and again, you don't have that as a frame of reference of why they've made those decisions. So you want some insight on how that decision, you came to that decision. So it's a case of a good student's asking questions, a bad student's one that's quiet in the corner.
Okay. So you don't want to be a yes man. Okay.
I wouldn't want somebody just to continue to agree with me, because I'd want somebody to say, well, have you thought about doing it this way, or have you thought about doing this? Because one of the things I learned teaching nursing recently is you can do something, and lots of people in sort of healthcare will continue to do things as things have been done. So you'll see and even in podiatry, I'll say, why did you do it that way? Because that's the way it's always been done. And I was like, yeah, but why has it always been done like that? Is there a new and a better way of doing it? So I would say is I'll use this as an example. I graduated in 2001, 2002. They brought in the POMS S. Okay, so I missed out. I had to do an extra course to top myself up. But although that started in 2002, you only really kind of saw widespread use of that over the last 10 years or so by practitioners.
Interesting.
So you got to think, if you've got a practitioner who graduated in 2002, their superior or their band 7, band 8, they wouldn't have necessarily had that qualification unless they'd actively gone and got that qualification. Then once that person who graduated in 2002 gets into that band 7, band 8, they might start introducing things into place where we can start using those entitlements a lot easier, and it's a lot more, the process is a lot easier for us. And then so that might take about 6-7 years to get through. So change in practice takes a long time.
Yeah.
So if you can have all the evidence in the world, but practice still the same.
So how do you speed that up? Because I feel like that's such a big gap.
And that's where students come in. That's where students come in. And then where us as more experienced podiatrists or experienced health practitioners, you guys are teaching us.
Okay. I would never have seen it that way.
So education is always a two-way street. If you're engaging with a student in terms of explaining what you're doing, they might come back to you and say, oh, that thinking has changed now. And that's the bit that scares me, is that I'm doing stuff is that actually still current practice, or is it out of date? You can keep yourself read up on journals and books as much as you can, but when it comes to things that you're treating with patients and things that I know that work, there may not be the best evidence base for it, but I know the patient's going to benefit from it. That still is, and then having that discussion with the student, that's going to go two ways. They say, oh, but that's what they used to do, but now they're trying to do this.
Right. Also, would CPD courses be, I mean, I'm assuming they would be very up to date on current practice. So can you also take a CPD course if you wanted to top up?
Yeah, well, one of the interesting things was I was teaching basic life support for nursing over COVID. These courses can change, and the requirements can change rapidly. So on April the 1st, the Resuscitation Council came up with their first round of recommendations. They were on version 6 by the 14th of May. So that was they changed every week their recommendations in terms of what you should be doing for basic life support.
Wow.
So things can change very quickly, but then making sure that if you're delivering that, are you staying up to date with that? Are you kind of in line with what evidence is out there?
Right.
So it's a two-way street. So I'd hope that you guys are coming out with the most up-to-date, most recent info.
Yes, we are. Yes, we are.
Like when I was a student and I graduated, we had a cupboard full of wonderful medicaments. We had monochlor, dichlor, trichloroacetic acid, salicylic acids in 20, 40, 60%. We had all sorts of wonderful, weird and wonderful things. And there were, our lecturers then were telling us about crystal violet, which was shown to be carcinogenic and has been taken off use. One of the lovely things I liked using was something called pyrogalol. Have you come across that? Come across that? That really old. Again, you don't use it anymore because it's carcinogenic. So there are things that have moved on that I could say, oh, I'd love to use that on that patient, but it's just not available anymore, and it's not appropriate to use anymore. So things will change where where what's in your toolbox changes. And that's what I always talk about is you have a toolbox of of treatments, and it's then selecting the right tool for the right job.
That's a great metaphor, actually. Like that metaphor can go a really long way.
Yeah, it's like you're not going to hit every nail with the same hammer. Depends on how big the nail is.
That's true. Yeah. Yeah. I agree.
So you got to think about how do you make that decision, that clinical decision to use that treatment.
Before we go today, what advice do you have for students when
Ask
they're thinking about clinical decision making?
ask questions. Ask lots and lots of questions. Uh, be annoying. Ask that extra question that you just want to get to know, and you will find that half the class will probably still be thinking the same thing.
Okay.
And then it's ask that question, why have you done that for that patient? And it's always, like I said, it's always those three things. It's about you, what's your prism of view, what's your patient's expectation, and what do they want to get out of this of the interaction with you, and then finally, what does the evidence say? So it's always that three points that you need to be thinking about, and how you kind of come to that decision, and how you process that with the patient.
Okay. That's amazing. Thank you so much. Thank you for taking the time to talk to me today.
That's fine. I could talk about ages. I'll talk about this for ages. Didn't even get to the fun things of pattern recognition and hypothetical deductive reasoning.
That could be part two.
That could be. That could be. They're really good things because they really examine how you look at your own biases.
Oh, okay. We're gonna have to save that for part two, definitely, because I feel like that's a very interesting topic and I want to know more. All right, we'll see you next time. Thank you.
Yeah.
Bye-bye.
Cheers. Bye.